Welcome back to The Explainer. Today we're diving right into part 3 of our clinical coding deep dive, focusing heavily on hypertension. We're moving way past the basics now, tackling the tricky stuff you see every single day. We're talking secondary hypertension, resistant cases, those high-stakes hypertensive crises, and even transient elevated readings. Getting these right is absolutely crucial. It's not just about ticking compliance boxes, It's about accurately reflecting how sick your patient truly is. If we undercode or mess up the sequencing, the facility literally loses out on reimbursement for the actual complexity of care provided, and the patient's record is just incomplete. So let's get into it. Here is what we're covering today. First, hypertension with heart disease. Second, secondary hypertension guidelines. Third, hypertensive crises. And fourth, transient hypertension. Let's jump right in. Section 1. Hypertension with heart disease. Let's look at how we handle chronic conditions when high blood pressure pairs up with a cardiac diagnosis. This brings us to the absolute power of the ICD-10 with guideline. You know how much words matter in clinical coding? Well, when you see heart conditions in that I-51.4 to I-51.9 range, things like unspecified myocarditis or ill-defined heart diseases, and the patient also has a history of hypertension, the guidelines do something kind of magical. You actually assume a cause and effect relationship by default. This is a huge time saver because you don't have to constantly query the physician to connect those dots. Because of this assumed link, you just combine them straight into category I-11.9, hypertensive heart disease without heart failure. It perfectly acknowledges that, realistically, the heart rarely escapes the long-term impact of systemic vascular pressure. But there's always an exception, right? By default, you combine them into I-11.9, plus your additional code for the specific heart disease. But, and this is a massive but, if the provider explicitly documents that the heart disease and the hypertension are completely unrelated, you must separate them. Say the patient has a congenital heart defect. That obviously has nothing to do with their essential hypertension. In that case, the assumed link is officially broken. You code the hypertension entirely separately from the cardiac issue. Ultimately, the clinical documentation is your compass here. If the doctor says they aren't linked, we don't link them. All right, moving on to Section 2, Secondary Hypertension Guidelines. Let's see how causational coding works in these scenarios. So, unlike essential hypertension, secondary hypertension actually has a direct, identifiable underlying cause. The trick here is knowing exactly which bucket your patient falls into. Are we looking at renovascular hypertension at I-15.0, renal hypertension at I-15.1, or maybe endocrine hypertension coded over to I-15.2? Capturing this accurately is super important because it paints a much clearer picture of etiology-driven high blood pressure. And hey, this is also where you'll frequently see resistant hypertension pop up. If a patient is taking 3 or more antihypertensive meds from different classes, including a diuretic, and they still aren't hitting their goal, you're going to want to look at adding code I1A.0. You drop that right alongside the primary or secondary codes to capture that clinical resistance. It's a real game changer for accurately showing patient risk. Now pay close attention to this specific guideline directive. See that massive red flag right under the I-15 heading? It says code also underlying condition. That's a mandatory dual coding rule. You absolutely cannot just drop an I-15 code on a chart and call it a day. The system demands that you report what's actually causing the high blood pressure. If you miss this, you're looking at instant claim denials and some potentially huge DRG mismatches. You'd basically be telling the payer, hey, the patient has a secondary condition, without telling them the primary driver. It just doesn't make sense. Let's walk through a real-world example. Imagine a 48-year-old guy comes in with severe dizziness, and the doc writes down secondary hypertension due to renal artery arteriosclerosis. Okay, step 1, we identify the underlying culprit, the arteriosclerosis. That's I-70.1. Step 2, we grab our secondary hypertension code, which is I-15.0 for the renal vascular piece. Step 3, we sequence. The golden rule for etiology and manifestation is strict. The underlying cause, I-70.1, always goes first. It's the main driver. The secondary hypertension, I-15.0, is just the manifestation, so it goes second. Boom. Now you've told a perfectly compliant clinical story. Section 3. Hypertensive crises. We are escalating now from chronic issues to high-stakes acute emergencies. When a patient's numbers shoot up into the red zone, we're talking severe spikes like 180 over 120 or even higher, we completely leave the standard I-10 or I-15 codes behind. We're now strictly in category I-16 territory for documented crises. These are highly volatile situations. But remember, not all crises are coded the same. Getting this right is literally a matter of accurately reporting the severity of illness for the facility. This matrix really breaks down your options nicely. If the documentation says hypertensive urgency, that's I16.0, it means the pressure is dangerously high, but there's no acute organ damage happening just yet. The organs are stressed, but they're holding on. But look at hypertensive emergency, I16.1. For this one, you are strictly required to code also the specific acute organ dysfunction happening at that moment. Is it an acute kidney injury, a sudden cerebral hemorrhage? You absolutely must have that secondary code to validate the emergency status to an auditor. Without it, it's just not a verified emergency. And if the doc just jots down hypertensive crisis, without any extra details, you gotta default to I16.9, unspecified. Now never forget this golden rule. Alongside your I16 acute crisis code, you still have to code the patient's underlying hypertensive disease. Whether it's essential hypertension, that renovascular issue we discussed, or even resistant hypertension under I10.0, you code that too. You have to capture the baseline disease that's suddenly flared up. So which one goes first? Well, it's not automatic. The sequencing is based entirely on the primary reason for that specific encounter. A quick pro tip, always scour the history and physical or the discharge summary to figure out why they were admitted. Did the crisis itself bring them in, or did a chronic issue flare up while they were there for something else? Section 4, transient hypertension. Let's de-escalate a bit and talk about isolated, temporary events. Because look, not every high blood pressure reading means a patient has a chronic disease. Transient hypertension is all about those sudden, temporary spikes that just go back to normal on their own. No meds needed. They can be triggered by all sorts of everyday things. Acute stress, a sudden anxiety attack, heavy drinking, or maybe just eating way too much salt that day. A perfect example is white coat syndrome, where a perfectly healthy person's pressure spikes simply because they're anxious about being at the doctor's office. It's just a moment in time, not a systemic disease. For these isolated, incidental spikes, where there's no formal clinical diagnosis of hypertension, R03.0 is your best friend. It literally means elevated blood pressure reading without diagnosis of hypertension. It's such a helpful code. It lets you accurately record their abnormal vitals for that visit without unfairly slapping them with a lifelong chronic condition code they don't actually have. Trust me, you do not want to mess up their future insurance premiums or medical profiling over one stressful day. As we wrap up this explainer, I want to leave you with a scenario. Think about this. You have an acute hypertensive emergency, I16.1, and an underlying renovascular hypertension, I15.0. Based on everything we just went over, which code comes first? Remember that golden rule? It depends entirely on the reason for the encounter. If they were admitted specifically to manage the acute organ failure, I16.1 probably leads. If they came in for the renal artery issue, well, that changes the whole picture. Documentation is literally everything. Keep practicing these guidelines, and next time we'll be tackling some interesting outliers, pulmonary hypertension in the I27 category, and the nuances of chronic venous hypertension, including those complex ulcer codes under I87.3. Until then, keep your coding sharp, and I'll catch you in the next explainer.